If we move on now to the second presentation by Trevor Single, who's the Chief Executive Officer for Telecare Services Association in the UK. And Trevor's going to be, presentation is based on 3 million lives, the challenges and opportunities for mainstreaming telecare and telehealth. Thank you, Trevor.
Okay. Good morning, and pleasure to be here. Can I start by just giving you a little bit of background on what the TSA is about? So we're a trade body representing both telecare and telehealth service providers in the UK. So we've got a membership of just over 370 organisations, and that provides the full spectrum of service delivery in both telecare and telehealth. So that's right from a monitoring centre and the evaluation and assessment of an individual through to those that are actually doing the monitoring, the million service users in the UK with either telecare or telehealth. Predominant amount of that is in terms of telecare, but telehealth is now and will start to grow much more within the UK. The other important factor about the TSA is that we've been very pioneering in actually driving through service standards for users in terms of what's the level of service, what's the guaranteed service that they should be receiving. And so we've got a comprehensive code of practice that's the first in the world that actually addresses what's the quality standards that an end user should be looking for in terms of that service delivery. And currently over 140 of our organisations are actually accredited to that standard. But why do we need to promote telecare and telehealth? Well, quite bluntly, it's because we're on a burning platform. I think in fairness, some are well aware that we're on a burning platform. Others don't even realise that at the moment in terms of where we are with health and social care. And others are looking very much for, well, okay, we're on this burning platform, but where do we go? What's the route out? But as the previous speaker said, essentially we've got a ticking time bomb that's going on. We've got an ageing population. We've got a shortage of care professionals and also of carers, those who may well give up professional capabilities and other work requirements in order to fulfill a caring capacity. There is a dramatic shortage of those, certainly within our UK and others. But also all of this is leading to an increased demand on both residential and nursing home requirements. So it's all totally unsustainable in terms of the way forward in terms of health and social care. And just to illustrate that, I mean, just in a sense to further emphasise it, we've got a population age profile that's on the increase, we've got chronic disease that's on the increase, and budgets increasingly under pressure, if not on a diminishing scale in terms of their availability. And coupled with that is actually a growing expectation from us as users, as consumers of health and social care, that our expectations are increasing. And the tension and the balance from that means that we have to look at alternative ways of actually providing service. So what do I see as the challenges and certainly the opportunities for mainstreaming, in particular telehealth? Certainly within the UK market, telecare is well established, and probably of that 1.7 million, about 1.6 million plus are receiving telecare service. So that's well established. But actually, what do we do and how do we mainstream telehealth? The problem certainly that I've seen up until now is that we've done a number of pilots to actually test what's the effectiveness of telehealth. In the main, it's involved just a small number of patients and for a set period. And then the patients are actually then returned to mainstream healthcare. So we test for a period of 18 months, 3 years, and then it drops back off again. And it tends to be additional to the way in which healthcare is actually being provided. It's not embedded within that process. So actually the business model does not change in terms of the way in which services are being delivered. And all that we end up with doing is testing an additionality in terms of the use of technology to support an individual, rather than actually mainstreaming it. So what's the way forward? Well, it isn't just doing what we did in the old way, purely electronically now. Actually, it's looking at it, as I said, in terms of integrating that way forward. So the UK, and this brings me on to the 3 million lives aspect, decided that what it wanted to do was to really embark on a significant program to actually test the value of both telecare and telehealth and what it's actually capable of delivering. So it was the largest randomized clinical trial that had been undertaken anywhere in the world, specifically in terms of reviewing both telecare and telehealth. 3 projects or 3 locations were identified for it, quite different locations, each of them, in terms of one being in the East End of London, so quite a deprived but a very multicultural environment with a huge number of challenges from that point of view. Kent, which was a sort of affluent, semi-urban, semi-rural type area, but very much a sort of commuter belt for people going into London. And Cornwall, which great from a tourist point of view, but actually low income within that area. So quite a deprived area in a different way from that point of view. And about 2,000 patients were looked at and tested as part of that. Now the intent was very much in terms of testing what's the effectiveness of telecare and telehealth, how does it work, how does it support the patient, and how does it encourage them actually to start to be responsible for their own health and care provision. The headline findings out from that were dramatic, to say the least, and I think shocked everybody in terms of the extent of it. Just looking purely at the mortality rate, in terms of a reduction for those that were being supported by technology of 45%, but also in terms of addressing what we saw as very key areas in terms of emergency admissions and occupancy of hospital beds, etc. Again, significant reductions on those. And I would say quite clearly that mortality rate of reducing it by 45%, if that was a cancer drug, that would be adopted tomorrow in terms of saying, actually, technology works, it's been proven that it works, it is saving lives, we should be implementing it tomorrow. Interestingly, because there was a lot of criticism that maybe quality of life would diminish because people would feel more isolated by being supported by technology rather than a regular engagement with the clinicians. But actually what came out from that trial was broadly quality of life remained much the same. I think one of the main criticisms that's come through about the whole system demonstrator is about cost. And that has been seized upon in many ways by those who are opposed to the use of technology as a reason for not adopting it. But actually, the project was never intended to test cost. And if you go back to one of my earlier slides, actually, in a number of cases, in terms of supporting those patients with technology, it was additional to the current services that were being provided to them. So measuring cost was not appropriate in terms of that project, but it's one that's been used as an argument against it. Now, actually, the other point that came out very clearly from one of the academic papers produced on it was to say that actually, given that that was using technology in that whole system demonstrator that is now 5-8 years old at least, actually the way in which technology has moved on, the costs have diminished significantly, and actually there is much more of a saving that can actually be achieved by the result of that. So the outcome from that really was very much that certainly David Cameron as Prime Minister said, right, okay, actually we tested it. The results in terms of those headlines are hugely successful, so we want to get on with it. And David Cameron actually then launched this 3 million lives, which was about looking at the fact in terms of saying, given that we're already supporting a number of people with technology, how can we support another 3 million? And with an aspiration that within 5 years, we would be looking and moving that forward to actually doing that. And that was a similar endorsement by David Nicholson, who was at that stage Chief Exec of the NHS. So that was the 3 million lives, and it was actually about transforming the lives of 3 million people over the next 5 years. But moving on very swiftly, there are a number of barriers really to actually achieving that goal or that aspiration. One is about how do we raise the awareness? How do we raise the awareness both across consumers in terms of driving a bottom-up model, technology is the way forward. But we've also got to include levers and incentives to actually encourage them to take that up. And being quite blunt, again, we probably need to look at financial incentives, because those are the real levers that make people quite often react and adopt and move forward. Organisational readiness has to be embedded within that. Again, coming back to an earlier comment, it has to be embedded within the structure of that organisation in terms of technology being a recognised approach. It's part of the patient's care pathway in terms of supporting them, so it's not an additional. But also quality standards, and that's what our association has been doing a lot of work with, is absolutely fundamental in terms of underpinning the level of service that's actually provided to them. And in that way, we can then start to build that marketplace. And we can build it so that we're not just looking at very small, isolated projects and pilots that work for a short period and then are stopped. And patients are actually then dropped off from being supported. But actually what we're building is mainstreamed embracing of technology within the care pathways. So what do we need to do? We need to empower the commissioners so that they're ready to actually take forward technology and to adopt it and use it in the right way. And that we provide them with examples of best practice and case studies and the way forward. As an association, we're working very much at the moment on improving the stakeholder communication and actually driving that message through that the bottom-up and the top-down approach has to come together in terms of delivering this as a technological solution and an enabler for both patients being supported. We have to build that model of mainstreaming activity, but that can only be achieved by a partnership approach rather than a contractual approach between those that are actually able to provide that service and the commissioners. And we've got to ensure the governance is actually there that enables a rapid scale out. What do those service components start to look like? Well, this is just a slide that sort of runs through that very briefly, but it is the whole patient journey. It's right from that very point of the initial assessment of a patient in terms of what their needs are, what their risks are, how that can best be addressed, what's the care or the clinical pathway that is being set for that individual, and then looking at that holistically as an integrated care model. How do we support that individual, and how does technology become an enabler as part of that? So finally, what are the challenges that we face? Well, certainly within the UK, 75% of the NHS resources in England alone are actually going on supporting those that have got at least one long-term condition. And when you start to look at what the forecasts are in terms of what the percentage of national wealth that has to be devoted to be able to support health and social care, it's a totally unsustainable model. We cannot quite simply carry on providing health and social care in the way in which we have done previously. We have to move it much more out into the community to support that individual. Quite literally, we have come to a fork in the road and we have to go one way or the other. Thank you very much, ladies and gentlemen.
About actually setting up these as test beds or actually trying to make mainstream them is an important one. And what I see, with the Australian experience, that we are developing these services, but they're now additional services. Nobody's saying, oh, we'll now close down the ED in this particular area also. Right, yeah. So it's how you get that part of the equation happening too. I was interested in your ideas. Yeah,
and that's certainly the same. I want to congratulate Australia because I think whereas we're in a dilemma in terms of precisely which way do we move forward with it, what I've seen, and certainly the signals coming out from Australia are very positive in terms of what you're doing. But it comes back to the levers and the incentives that I've indicated up there. Financially in the UK, it is not in the interests of the hospitals and the clinicians within the hospitals to say, actually, we want to support people within the community because the budgets are sitting in the wrong place. And therefore, they will then lose a ward, they will lose their budget. And so what we've got to look at is actually the integration of that care and that support of that individual and using the resources as they are appropriately used rather than siloed operation. At the moment, we are very much in a siloed operation in terms of the budgets in the UK.
Any other questions at all? Thank you. I think it's an interesting topic, Trevor, and I think there are plenty of challenges that we face in the UK as well as everywhere else. Yeah, thank you very much for your presentation.